They pretty much use the same philosophy actually, I'm going to teach you NDT, which is neurodevelopmental treatment, but realize that everybody takes a little bit from everything that they've been taught. Do y'all remember what neurodevelopmental treatment is? What's the philosophy there? You take the affected extremity and you try to make it as normal as possible. So you don't utilize spasticity for function, you try to decrease spasticity and facilitate normal movement. So that's what, I think you see that pretty much across the board now. I think people do that. They just use different types, so they're not, oh, all I'm going to do is NDT, or all I'm going to do is this. So with stroke rehab, it's kind of that way, but also with kids who have maybe cerebral palsy, head injury patients, any type of patient that it has some kind of neurological deficit. So, cerebral vascular accident, sudden focal neurological deficit resulting from ischemic or homogeneous lesions in the brain. So what's the difference between those two? What's ischemic? You're not getting enough blood to it. So that happens like a blood clot. What is hemorrhage? So what causes the hemorrhage in the brain?
Aneurysm or blood vessel?
Yeah, so that would be an aneurysm. So like an aneurysm that has caused bleeding in the brain. So a hemorrhage is always bleeding. When they take patients in who they think have had a stroke, what's the first thing they do with them in the ER? They give them a CAT scan, because they have to see if it's hemorrhagic or whether it's ischemic. Because they can give them the clot buster if it's ischemic, but if it's hemorrhagic, they're just going to cause more bleeding. So that's why they do that immediately if they think someone's had a stroke. Because we're going to talk about the miracle drug that they've done with strokes, and it's just really neat to see the effect of where you're seeing less and less residuals with a stroke because of this drug. It's exciting. Okay, there are three major causes of strokes. A thrombus, remember, what is a thrombus? You who are in my medical terminology class. Right, so it's where you have buildup on the side of the wall. So it's actually just a buildup. So blood clot and cerebral arteries are branches attached to the wall. So it's normally attached. What's an embolus or an emboli?
Traveling.
Right, so it's a traveling, something that's going through the body. Maybe something broke off from the heart. Maybe there was a piece of cartilage somewhere that got into the bloodstream. Maybe there was air. So there's all kinds of things that can cause an embolus. And that embolus are probably the most common strokes, I would say. And then a hemorrhage is when you have some kind of a bleed. You can also have a hemorrhage, a subdural hematoma, which happens with head injury patients and happens a lot with motorcycle wrecks, where they just start bleeding in the brain. And so that's also a hemorrhagic situation. And so it can be from a ruptured aneurysm, or it can be, we're going to talk about atrioventricular malformations, which can cause a rupture. And so those are the three major types of a stroke. And basically your neurological deficits represent what area of the brain that's affected. We're going to talk about if it's in the frontal part, what is the most common stroke?
Cerebellum?
Yeah, the cerebrum would be the most common. And we think of a stroke as being paralyzed on one side. If they're paralyzed on the right side, they have trouble speaking. So those are kind of your typical strokes, but there's also other kinds of strokes. So it basically depends on how much ischemia they have as to whether the deficits are there. Some risk factors, and y'all know these: hypertension, heart disease, diabetes mellitus is a big one. Smoking, little TIAs. TIAs are always interesting because they really do not that doesn't mean someone's going to have a major stroke if they have TIAs. So it's y'all know what a TIA is? It's transient. What's transient mean? It comes and goes, right? So a TIA is a little stroke is what they call it, but that's not really a true definition. Transient ischemic attack is a temporary interference with blood supply to the brain. And the symptoms will last for up to maybe 2 or 3 hours, and then they have to completely disappear for it to be considered a TIA. If they have residuals after this 3-hour period of time, then they've had a stroke. Okay, so a TIA is just a little, something has gone in there and cut off the blood supply, and then it's released it and it's okay. You'll have people say, oh, my face was numb. I was numb in my arm. I couldn't move my hand. And then all of a sudden it came back. So that's kind of what a little TIA is. 10% of CVAs have had TIAs prior to the major CVA. And then 36% of TIA patients will develop a stroke in 5 years. So it does, if you have TIAs, with all the medication that we can give now and everything that they can do to stop it, then they don't necessarily mean you're going to have a major stroke if you have them. And a lot of times you don't, you just have to keep having little TIAs. Any questions on that? Secondary facts are physical inactivity, obesity, excessive alcohol use, increase in blood cholesterol and lipids. We know all these. Okay, types of strokes. Probably the most common is the major stroke, and that's what we think about. Remember that once someone's had a stroke, they're not going to get any worse. Unless it's a bleed. If it's a deteriorating stroke, they will, and that means they're having a hemorrhage. But with a stroke, they have the stroke, and then that's what you're going to have. It's usually stable deficits. And so the deteriorating stroke is normally what is the hemorrhage, and they continue to bleed out, and so that pressure builds up, and so they get worse and worse and worse. And so sometimes they can stop that bleeding, sometimes they can't. They just have to sit back and watch and see what happens. A young stroke is considered younger than 45 years of age, and they normally have very severe strokes if they have a stroke at a young age. Most common sites, it can be in the common carotid artery, the carotid sinus and the internal carotid artery, the middle cerebral artery at the main bifurcation. Remember that middle cerebral artery had kind of a little twist to it where it was almost like a 90-degree turn in there. I don't know if y'all remember that. And then it goes out. Y'all need to review your blood supply to the brain. And so this is the bifurcation that they're talking about right here in the middle cerebral artery. So that's what that's talking about. So those are the most common sites where strokes happen. Any questions on that? Okay, there's your blood supply. Y'all remember that? Go back and pull your neuro notes out and review that. What is the most common artery of stroke? Middle cerebral. Is that part of the cerebral system, or the carotid system, or the vertebral system? Carotid. So go back and review all that. Again, we're seeing such wonderful this wonder drug that they've done for these stroke patients, and it needs to be within, I believe, 3 hours for it to be effective. Although I think they give it up to 5 hours. So this is why they've tried to educate people on television so much about it, so that if you think you're having a stroke, you need to get to the ER. And they will definitely immediately put people in that they think are having a stroke. They'll do the CAT scan and they'll get the medication to them if they're not a bleed. So they do a CT scan to check for bleeding, and if not, they get what's called the clot buster, and that's the TPA, and so that's what that's called. It's been really neat to see. Probably the most significant things that I have seen when people get the TPA is they don't have as much residual in the arm. And their legs better. They just have a less severe stroke, but that makes sense, right? They get that blood supply, that clot is broken up because of that clot buster, and it allows that blood supply to come back in there, and they just are not as severe. It's really, it's been very exciting to see that. Some of the signs for a stroke are numbness, weakness or paralysis of the face, arm, leg on one side or both sides, trouble speaking, decreased vision or blurring, dizziness, loss of balance, difficult swallowing, sudden headache or confusion. All of these are neurological signs. So, neurological is just a way to look at that, in that, even looking for your family member. Okay. Some of the things that you have to deal with that causes, of course, they're kind of in shock, is a cerebral edema. It begins within hours of insult. It reaches the maximum level of approximately 4 days, and it subsides by approximately 3 weeks. And it is what causes death in a stroke is the swelling. Probably what I would say here is, if they get the swelling down, right, then they do better. And the other thing to look at is how soon do you think they're moving people into rehab after a stroke? You think they're keeping them for 3 weeks in acute care? So we know that it takes about 3 weeks for all that swelling to go down. So how much of their rehab time do they actually miss if they're a real very severe stroke? 2 to 3 weeks. Sometimes they're home before the swelling's done. Sometimes they go on to skilled care. So we basically don't do our rehab is based more on a money thing than it is the best for this patient. So that's just the way life is today, isn't it? Okay, we're going to talk about the middle cerebral artery stroke. This is the most common. This is the one we think about where you have paralysis on one side and maybe numbness and paralysis in the face. It is the most common side of stroke. It supplies the lateral aspect of all 4 lobes of the cerebral cortex. There are 2 types. There's a superficial lesion, and then there's a deep lesion. So if you have a superficial lesion, what's the difference between hemiparesis and hemiplegia?
Just with sensation.
No, but that's a good guess. And it kind of is. Hemiparesis is not as severe. They still are able to move it. Sometimes the sensation is affected. Sometimes they're just weak from it, and it might have some spasm, but they can still move it. So it's less severe. Hemiplegia is what you think of as being really a severe stroke. That's hemiplegia. So you have hemiparesis or hemiplegia on the contralateral side, sensory impairment of the face, arm, and leg on the contralateral side, and then you have hemianopsia, which is visual deficit in the right and left half of the eye on the contralateral side. So a lot of times this is where your visual thing comes into play in sensory and what they can see. What they do is they perceive that they can see everything, and they really can only see to about right here, or maybe even just here. So they're not seeing this whole side, this whole part of it, if it's on the stroke side. So they can only see like right here. What's interesting, I've seen patients who are real severe, and you'll put a plate in front of them of food, and they will only eat the food on half the plate. They don't see that other food. It's the weirdest thing, and it's a perceptual deficit that happens sometimes with a stroke. And it's a visual thing. They literally can't see it. So if you're sitting on this side of the room and you're talking to them, they can hear you, but they don't know who you are, and it's very confusing for them. So, and not everybody has the hemianopsia, but it is part of a stroke sometimes. Have any of y'all dealt with that with your strokes? Yeah.
My grandma has that, where I kind of, like, if I'm coming around that side of her, I always swing real wide so she can see me out front, and I don't startle her. One thing that she has is, like, hypersensitivity to sound, like across the house. I can, drop something on the table and she'll like jump and say, ah, and she's like 100 feet away. So I don't, what is that?
Well, sometimes just a hypersensitivity that develops with them with a stroke, and some of it may be even her fear, some of the fear that goes with it, but I've seen it before. I've seen hypersensitivity in that someone will touch them on that side and they'll, react. Does she do that also? Is she kind of jumpy about
Yeah.
that? Well, and even coming around her, see, she's fearful because she can't see that side. And so, fear does a weird thing in our lives. It makes us react in different ways than we would otherwise. So I'm guessing part of that's fear. But anyway, okay. So we have the superficial lesion. The deep lesion, and the superficial is what we consider a normal stroke. That's what we're talking about, just paralyzed on one side like we're talking about. A deep lesion are really great to work with. They are pure motor deficits. All you deal with, you don't deal with any sensory or visual deficits. So it's deep enough in there that it's not affecting the vision or the perception or the sensation. And so anytime you just have pure motor hemiplegia, it's great, because what's hard to deal with a lot of times is the sensory part of it, where they can't perceive what's going on, or they don't feel, or they don't even, sometimes if it's real severe, they don't even think that arm belongs to them. Have y'all dealt with that severity? I mean, they don't even think that arm is theirs. They'll name it something different, which I disagree with. They'll name their arm. It's a weird thing. But it's like it's not even their arm. So sensory issues really cause a lot of problems with rehab. So a deep lesion with a middle cerebral artery stroke is pure motor. Okay? It is a middle cerebral artery stroke is a typical stroke. You have paralysis on one side of the body. If paralysis is on the right, usually speech is involved. You need to remember these terms. Aphasia has to do with your speech. What's aphasia? G-I-A. Swallowing. So remember those. You have global aphasia, you have receptive aphasia, and you have expressive aphasia. So if you have receptive, then you're not understanding what people are saying to you. If you have expressive, you can't speak to them. You can't, that's part of the Broca's area. But global means you have both, which is very difficult if it's real severe. Do y'all have were y'all around some aphasic patients? Anybody do some stroke rehab with an aphasic patient? It's very hard on them, because it's hard when you can't communicate, isn't it? So, okay, so the next one is the anterior cerebral artery stroke, and these are really interesting to work with. One summer I worked with 3. They were all females, and they're very uncommon. They have hemiparesis on the contralateral side, just like a regular stroke, but it's hemiparesis. It's not normally. They still have movement in that arm. Greater involvement in the lower extremity than the upper extremity. Remember, with the normal middle cerebral artery stroke, the involvement is more in the arm, right? Usually the arm is more affected. And then the most interesting thing that happens with these guys is they have this involuntary grasp reflex in their hand. So they grab hold of something, like on the side of their chair, and they cannot let it go. It is the weirdest thing. So you spend time actually doing therapy, teaching them to let that go. It's just they grab hold and they just don't let go. It's one of the things that tells you where that stroke is. Because when you get information on a patient, it rarely tells you where the stroke happened. It's just, they've had a left CVA, that's what you get. Hopefully you get that. And so it's really nice to have an idea, like have an MRI or a CAT scan information to tell you exactly where the stroke is. An anterior cerebral artery stroke has a lot of problems with incontinence. They have significant memory loss and behavior impairment. So anytime you have behavior impairment, that is a bad deal, isn't it? Because then you're dealing with a new person, you're dealing with a new personality. And so that goes into psychosocial aspects for that family. They do have expressive aphasia with this. And then they also have apraxia and agraphia. So what's apraxia?
Reading.
Agraphia is writing. Apraxia is where they can't figure out how to do something. Like they can't figure out how to dress. They can't figure out how to put their clothes on. So that's apraxia. They can't initiate that and get that going. So that's a common thing with the anterior cerebral artery stroke. If it's an internal carotid artery stroke, then it's a combination of the two, and these guys are really messed up. So those are kind of your different types of strokes. Okay, so the posterior cerebral artery stroke is interesting. I do not know that I've ever worked with this patient. I don't think I've ever even seen one. But they have hemianesthesia, which would be they have sensory loss on the contralateral side. They have hemianopsia, which is the visual thing, and they have amnesia. So it is affecting the temporal lobe, is where part of this is. And then they have athetoid posturing with postural tremors. So what is athetoid posturing? We've talked about athetoid. What's that mean? If you're dealing with a cerebral palsy that's an athetoid patient. There are so few athetoid people around anymore that you rarely see them. They used to be real common. Because of, I think I told y'all, because of all the C-sections that they're doing, we're seeing less athetoid CP. But athetoid movement is this movement. They're just continually moving. And then this one, they've also got a tremor. But it's an athetoid movement is they may be sitting there and they start reaching out with their hand and their hand goes crazy. So have y'all ever seen a cerebral palsy athetoid that's sitting in a chair and they're all over the place like this and their arms and legs never quit moving? Woo, good. That means we have less and less. That really is less than it used to be. But anyway, this goes with the posterior cerebral artery stroke. And then we're going to the brainstem, the vertebro-basilar artery stroke. I had a patient that has this last week. He is not real severe. He does have the hemianopsia where he literally cannot see. His is about right here, and he's very aware of it, which is unusual. He's very aware that he's had a stroke before, and actually in the same place. And so he was fairly ambulatory and was starting to really get his balance back and everything. But the main thing that he noticed is that hemianopsia with his. With the vertebro-basilar artery stroke, basically, if they have a complete occlusion report, it's fatal. Why? What do we know about the brainstem? Right, so your basic life functions are in the brainstem. So if it completely occludes that vertebral artery stroke, the vertebral artery, then you're going to block all that off and they're going to die. It is progressive, so it gets worse. They have horrible occipital headaches, diplopia, progressive hemi or quadriplegia. A coma is possible, so it can be pretty severe. And then they have what's called, some of them have locked-in syndrome, and you just need to be aware of this. Locked-in syndrome is when they have quadriplegia. They're unable to speak, but their consciousness is preserved. And literally the only thing they have movement-wise, when they have locked-in syndrome, is they can vertically move their eye up and down. That's all they have. So there are actually people that live with this. Most of them want to die, I would assume. But they have no movement whatsoever except this vertical gaze. And this happens in the brainstem stroke sometimes. They have only voluntary movement against the vertical gaze, and then most of them die. 59% of them die.
Do you think it's a lot because like they don't want to live anymore?
No, I think the severity of where it's at is why most of them die. But it's a horrible way to live, I can't imagine. There's a book that was written by a guy who someone sat and they figured out the alphabet by just doing numbers of vertical gazes. And he wrote a whole book about what it was like. Because they can't talk, they can't do anything. And so they'll be on tube feeding. I mean, it would be a tough way to live. But they're all there, their mind is normal. So anyway, he wrote a whole book. And I used to have it. I do not know what happened to that little book, but it was an interesting thing. Other things that happen with CVA is visual loss, facial numbness and weakness on the same side, tinnitus, dysarthria. What's dysarthria? Dysarthria is when you have it affects their speech because it affects the muscles around their mouth. So that's dysarthria. Their speech is affected because of the muscles around their mouth. Okay? Dysphagia, hemiparesis, pain and temperature loss on the affected side, drop attacks. Drop attacks can happen with CVAs, and it's really a mess. Literally, they'll be going along really well, and they're actually good ambulators, and all of a sudden, their knee will just buckle, and it just happens with some of them. And so, what does that do if you're dealing with an older lady or an older man? They can't ambulate by themselves. They'll never be able to be independent because it just kind of comes along. All of a sudden, that leg just buckles under them. And you'll have other neurological patients that will tell you that their legs just feel like all of a sudden they just buckle. Those are called drop attacks. And it just happens. It's like their brain is turned off somehow to their legs and they just drop. And it's just, I don't even know, why it happens, but it's part of a stroke sometimes in other neurological patients. Sometimes head injuries will have it.
What is tinnitus?
What is what?
The tinnitus?
Tinnitus is ringing in the ears, which is very irritating. Okay, so we've talked quite a bit about cerebellar stroke, so we're not going to go into a lot of detail. But remember that they're lots of fun to work with because they have such a good blood supply that they usually recover. They have ataxia, nystagmus, vertigo, nausea or vomiting, and then they have a lot of balance issues. Normally you don't see hemiplegia with them or hemiparesis, you just see more balance issues. If you can get past these are the patients that you have a trash can with you from the beginning because they'll throw up on you because they're just gone, and then all of a sudden it just starts getting better and they're just lots of fun. They do well. Okay, possible complications that go along. Shoulder pain is probably the biggest thing. 70 to 80% of CVA patients develop pain, a complex reflex sympathetic dystrophy type pain in that shoulder. So we really have to take care of that shoulder. Very, very important. Did the gentleman with Deanna on Tuesday, did he have any pain in his shoulder? Did they talk about it?
They used to have a lot of pain.
They what?
They used to.
He used to, so it's better. He's how many years out now?
6.
6. She started with him how many years ago? About 3? 4. He is a miracle to me because he's such a severe left Hemi, and his affect is so good. He can communicate so well and actually interact with you. I think when she first started working with him, that was not the case. So last year, he could not walk anywhere near as well as he's walking this year. I was amazed. He could, and I think she's able to walk with him some at home now by herself, is that correct?
They said he
I
does
think
stuff
so.
on his own.
So he's actually doing things on his own, so, that's called extremely supportive family. That little wife has been wonderful, and I think they have supportive kids, and they've just continued to do therapy when they get in there and do it, and he's just been very determined, but you don't always see that with the real severe left hemiplegia, because they have that affect where they're kind of blah. And, so, it's neat to see how well he's done. Anyway, so shoulder pain is 70–80%, so we can almost know what's gonna happen if it gets paralyzed in that shoulder, right? Flexion contractures are also a problem, and they can happen anywhere in the upper extremity, probably more so than in the lower. But it can be anywhere, so you always wanna watch for contractures and making sure you keep them stretched out. And you could see how that would happen even with him, because he was still pretty spastic in that leg. So you have to, what could he develop a contracture in? I would say plantar flexion. He could decrease his dorsiflexion, not be able to get that heel on the ground. So you'd really have to keep him stretched out at the ankle. Okay, so here are some symptoms that go with a typical right hemiplegia, which would be a left CVA. And there is a difference. Quite frankly, I would rather, if I'm gonna have one or the other, I'd rather be a right hemi than a left hemi. Left hemis are the ones who don't always think there's anything wrong with them, because it affects them more cognitively and just intellectually, really, it does. Verbal communication difficulties are with the right hemiplegia, such as receptive or expressive aphasia, right visual field deficits, decreased computer skills. So these guys have trouble speech, but they also can't do their books anymore. They can't take care of their finances anymore. Left-right confusion, deficits in memory, and a depression because they're very aware of their problem. So you see more depression with the right hemi. Left hemiplegia, you have the visual perceptual deficits, distractibility. These are the people who deny that there's anything wrong with them, and so they get up in the middle of the night, and God told them they could get up and walk, so they get up and walk and hit the floor. So these are the ones who fall at the hospital a lot. And so you have to be very careful with them. They're very impulsive, and they have more trouble with dressing apraxia on the left.